Good evening, everybody, and thank you so much for joining for this wonderful talk that we have in one of the series, which is of BONEFLIX. The talk is on denosumab, and it covers a very interesting topic of combination as well as sequential therapies when it comes to denosumab. And for this talk, we have Dr. Nitin with us, Nitin Kapoor. Thank you so much, Dr. Nitin, and our wonderful guest today, Dr. Manoj Wadhwa. He is the renowned orthopedic surgeon, and he needs no introduction. So, before we go on, I would hand it over to Dr. Nitin. Thank you so much, Dr. Nitin, and just let's kickstart this wonderful session and give that insights what orthopedicians have been waiting for. Right? Thank you.
Thank you, Nilesh, for that introduction. I think very good evening to one and all. I think it's a great pleasure to host this particular series of Med Talks on osteoporosis, which is indeed a very important topic. And it is our proud privilege to have with us our guest for today, Dr. Manoj Wadhwa, who, as Nilesh mentioned, needs no introduction. Dr. Manoj is the chairman and executive director of Elite Institute of Orthopedics, several hospitals in the Tri-City location, and previously was the head of the Department of Orthopedics in Max and Fortis. Warm welcome, Dr. Manoj. It's
Thanks,
really
Nitin.
great to
Thank you
have,
so much.
and really looking forward to discussing a lot of nitty-gritties about denosumab, which are really uh, very is a hot topic as of today. So today, friends, we are talking about osteoporosis. We know that osteoporosis is a big problem in India globally. We look at literature from India. We looked at data from Vellore. 50% of postmenopausal women have osteoporosis. That is one out of two women above the age of 50 have osteoporosis. But what is really threatening, or what is really dangerous, is the morbidity, the mortality, and the cost implications that we have once these women sustain a fragility fracture. And that's where our friends and colleagues from orthopedics come in, because I think Dr. Manoj, you would agree with me that no matter what treatment we offer, the morbidity, mortality, and the cost involved after maybe a fragility fracture of the hip is quite distressing. What would you say about that?
I think of course, I have a bias because I deal mainly with the geriatric population and I sort of open those bones every day in, day out, and I realize that the amount of osteopenia, osteoporosis that exists in our population is maybe at many times way higher than documented. That's what it is. And the one has to look into one word, and that's a cost benefit ratio, right? We many times keep thinking this is the amount I am flooding on my anti-resorptive therapy treatment or treatment of osteoporosis. But if you look at what cost you incur if unfortunately you have a fracture, and it is not only the cost of the surgical part, it's time value of money. So the amount of cumulative cost we all incur is really humongous. And that's a message we keep passing on to our society, to our different parameters, to our medical colleagues, to our orthopedic vitamin D3. And there is many more therapies, and that's I think what we will convey as a message to all listeners in the over the next few minutes, that what is the importance of newer therapies in osteoporosis management.
Absolutely. And I think also highlighting one other very important point, and that's where we from the endocrine fraternity needs to join hands with orthopedics, is one fracture begets another fracture. And that is the window of opportunity. Once the patient has presented to either the orthopedician or the endocrinologist or the physician and has sustained a fracture, if you don't intervene, that patient will come back with another fracture. And that's where these newer therapeutic agents are really helpful. Friends, the topic for today's discussion is breaking boundaries and exploring the benefits of denosumab in comorbid conditions. And maybe I might just start with asking Dr. Manoj the very basic question about denosumab. I know we have a lot of learned people who've joined us today evening, but maybe starting right in the beginning, Dr. Manoj, what would you say? What is denosumab as a molecule? How does it really help in osteoporosis and fractures?
So denosumab as a parameter I would broadly classify as a fully human monoclonal antibody used for the treatment of osteoporosis. The mechanism of action is it binds to receptor rankle that indicates potentiates its agonist, which is rankle. And basic ideology is to inhibit, to bind and inhibit the osteoclastic activity. So osteoclasts are substances that erode the bone. If we bind something to the osteoclast in the beginning and prevent osteoclasts from binding to the bone and eroding the bone, that what is the objective of treatment of osteoporosis. And today we feel that denosumab has a lot of indications, expansions in osteoporotic, not only the primary osteoporosis but many other substances like steroid induced and metastatic phases. So it has a very broad indication. And the basic ideology is you have to control and stop osteoclasts from beginning direction.
Absolutely. Very well said. So, we are talking of bone cells, and as Dr. Manoj rightly said, we are trying to inhibit the bad cell, the osteoclastic cell, trying to inhibit that with the help of this monoclonal antibody, and it is something which is very, very effective. We already have more than 2,000 registrations today. Warm welcome to Bimla Kapoor, Dr. Lambe, and good evening, and thank you for your wishes for this particular session. So, taking it forward, looking at the mechanism, we understand that we are inhibiting osteoclastic activity. If I may ask from your own experience, Dr. Wadhwa, where have you used it? In which all patients have you used it? You did mention a few, but just for our audience sake, where would be the
So
specific indications?
specific number one is the increase of the aging population. Now with a lot of medical modalities, Nitin, that you guys been across, the aging population spectrum is really going on, and there is equally a part where we want them to be healthy and alive. So in a basic profiling, it is used in the treatment of osteoporosis. Now there can be different indications. We want to prevent the incidence of fragility fractures in these osteoporotic patients. We also have a specific indication for post-menopausal osteoporosis, steroid-induced osteoporosis, in a lot of bone cancers across patients with, say, prostate cancer in men or breast cancer in women, or patients where we believe that they have a high risk category of fractures. As you rightly said, patient who presented maybe with a vertebral fracture once becomes a very high prone will either develop a vertebral fracture back again or any sort of a hip fracture. So those are the very kind of a target audience patients. Equally, at the patients who have impaired renal functions, these are again a very high target population. And a small spectrum where we find certain patients are not suitable or having difficulty in taking bisphosphonates. That also in our indication becomes one of the criteria where we would put them on denosumab.
Absolutely. So basically, trying to see I think the scope of using denosumab is really huge in clinical practice, especially in all the specialities who are dealing with aging population, who are dealing with bones, who are dealing with osteoporosis. It's not only just within the realms of orthopedics and endocrinologists. I think geriatricians, the general physicians per se, are also very much involved, and moving on further, even I would say gynecologists, because they also deal with a lot of postmenopausal women, and they also need to understand how the osteoporosis risk assessment needs to be done. So yes, we are trying to use this drug not only for primary osteoporosis, but as Dr. Wadhwa also said, even patients with secondary osteoporosis, be it steroid induced, be it malignancy induced, and we'll talk a little bit more about these specifics in a while. But overall, when we're looking at the different drugs that we have today in the Indian market for management of osteoporosis, we've had bisphosphonates for a very long time. We've also had anabolic agents like teriparatide, and now we have denosumab. So, if I may ask you, Dr. Manoj, how would you, use denosumab as against bisphosphonates, which have been there in the market for a very long time? So, how would you prefer one over the other, given that both of them are anti-resorptives?
Yeah, wonderful. So both are anti-absorptive. I have an experience with bisphosphonates going somewhere close to now 25 years. We initially started using this for osteoporosis and then AVN cases as extended indication. So the difference is in clinical outcomes when we see in changes helping in the bone mineral density, because we get a lot of BMD for our patients because my target audience is all geriatrics with arthritis with osteoporosis, and I see them both interlinked because the moment you have arthritis you are less ambulatory, you have more chances of being osteoporotic. So denosumab we found has a greater, a higher anti-resorptive effect than bisphosphonates. So, in general, if I would say that improving the BMD would would mean increasing or improving the condition of osteoporosis and decrease the occurrence of fractures. And in those cases, the effects were way faster. The indications were way higher for denosumab as compared to our old standard of bisphosphonates.
Absolutely right. So, as rightly mentioned, even I would say that sometimes when we use bisphosphonates and we don't see an adequate response, I think that's another place where we need to consider denosumab. But rightly mentioned, there are specific indications there where we definitely would prefer denosumab given the better efficacy that we have. We also welcome Dr. Ganesh Ambade and welcome to the show. And we have questions pouring in, and we would take questions from the audience as we go along. But maybe a very common question that often orthopedic doctors pose to us when we are talking in different meetings is a question that does denosumab help in fracture healing? So you've done a surgery for a patient with a fragility fracture. Would you give denosumab in that patient for fracture healing? What would be your experience? I know evidence in this area is limited.
So, very nicely placed, Dr. Nitin. This is one question that gets across from a lot of orthopedic colleagues, the role in the fracture healing in the current circumstances. So, my message would go on to orthos that whatever beautiful job you might do as far as the plating or any fixation or PFN or anything you'd go on, it's just a metal going inside the bone. The fact of the story is whether you use a titanium or a COCR or stainless steel, it doesn't make a difference. What is it? The bone has to heal. And you need to give anything that can augment that bone healing process. So, yes, denosumab helps in fracture healing by increasing the callus volume, the density, and its help in bridging the fracture gap in recalcitrant fractures. So these are the cases, a couple of cases where we tried where the fracture was not healing, it was going into delayed union, some sort of a non-union, and they were put on Denswab, and we found that we had a good deal of callus developing over the next few weeks to a months. So in all those cases where we went on, where we feel the patient is osteoporotic, where we feel that this patient is gonna be a slow healer, or in certain areas like subtrochanteric zone, where in itself the failure chances are very high, we put all our patients on Denswab now as a protocol.
So I think these are absolute pearls of wisdom. We wouldn't find them in any textbooks and journals. This is sheer from experience, and I have known Dr. Manoj's CV, and we know that he is renowned and rather world famous for the maximum number of joint replacements globally for all the records. And my next question, and this is from the audience that we see, the next question is in terms of in joint replacement, would you sometimes consider in patients who have severe osteoporosis for whom you have done a joint replacement surgery, would you consider combining teriparatide and denosumab?
We do it in a lot of our cases, especially the severe osteoporotic ones, where we feel that, like I went in for a hip, I saw a fragility fracture, and I found it to be very type C canal, a very osteoporotic, and there is a very high risk she will develop an intertrochanteric or a fracture neck in the other side or a vertebral fracture collapse, or where we go in for a total knees in patients who were on, say, who were CKD patients, or on patients who were on steroids for a longer time. These are the target audience of patients. The moment we see a bone stock, we see a bone stock that is compromised, we see osteoporosis, we see very loose kind of a tubercular pattern. These are the patients, the moment they are discharged, they are put on Denswab.
Absolutely. And following up another question in the same line, when we have these patients admitted with us in the hospital for
Hmm.
their surgery, orthopedic surgery, how soon can we give denosumab? And this is a very commonly asked question. Earlier days, there used to be some hesitancy, whether we can give it immediately or not. What do you do it in your practice? What would you recommend to all the orthopedicians who are joined with us today?
So this all started because the moment we were writing on alendronates and bisphosphonates, we were waiting because it used to impair fracture healing, by which the regime went on that osteoporotic regimens you start once the fracture healing happens up. Now I think this is game changer that has happened up. With Desubab, we start as early as 2 to 3 days post our fixation, and these patients are normally started on these therapies as denosumab alone. In all those patients where it is a very, very severe format, it's a combination of denosumab with teriparatide. That's a protocol we follow.
Absolutely. And I think a very clear message to all the listeners today. I think that is a very good window of opportunity when the patient is actually admitted after the fracture. They have been most affected or devastated after the fracture. And that's the best time to convince them that they need therapy for osteoporosis to prevent another fracture. Once time goes on, they go on to the OPD basis, they lose follow up, and they may not come back and they may miss that important injection that they need to give. So, even in our hospital at CMC Velo, we make sure that before the patient gets discharged after the surgery, we ensure that they receive their anti-osteoporotic therapy while in hospital, and very rightly said by Dr. Manoj. We have questions coming in further from audience, and Dr. Lambe has asked a question whether tenusumab is only advisable to be used in hospitals or can be used in routine clinical practice. Dr. Manoj, your comment to Dr.
So,
Lambe.
So unlike zoledronic acid and other parameters, this is a subcutaneous injection. So you can always use it very easily for a patient to teach them onto the thigh or the abdomen, just like any, because our endocrinologists are there, subcutaneous is your KRF field. Since it is a subcutaneous injection, I mean, of course, it's very, very easy to be used, if even if not in the hospital, at the home also. The safety profile is very high.
Absolutely. So it is indeed not only for the hospitals, for everybody in routine clinical practice. Very simple, like a subcutaneous injection. And I must say that diabetes today has landed up as one of the most important risk factors for developing osteoporosis. The Indian Society of Bone and Mineral Research guidelines that were published 2 years ago. And I think many of us were part of it. And we know that, a patient with diabetes is at risk for developing these fractures. Many of these patients with diabetes do take insulin, and unlike insulin, which is twice a day, thrice a day, this is once in 6 months. I think biannually, or
Yeah.
the different ways to tell it. So it is definitely doable on OPD basis in a routine clinical practice. We are not really looking at only high-end institutions or big hospitals to use it. So yes, that is indeed a very important question. So we're getting another question from the audience, and they are asking the question, when we use denosumab, or if you are using combination therapy in severe osteoporosis, we spoke about with teriparatide, do you have a specific approach, whether you use bone turnover markers to try and find out the fracture risk, or you depend on bone mineral density, or you depend on the fracture risk, maybe by fracs or something? What would be your comment on that?
So I would start from the back to the front. Fracture risk, you already know, you have already seen a fragility fracture, so this high risk population. The other very important target is the BMD. So we look at the BMD, if then the BMD at least score is lesser. Those are the kind of patients who are shifted to denosumab alone or a combination therapy. So is there any different protocol you follow, Dr. Nathan, in your endocrinology practice?
No. So, as you rightly said, fracture risk is known. And a very clear message that I leave everybody in the audience here is that, if somebody has had a fragility fracture, you just don't need to look at the BMD or BTMs or anything. That is enough an indication to start anti osteoporosis therapy. Yes, if you have severe osteoporosis, that you're looking at T scores after the age of 50, -3, -3.5, they have severe osteoporosis. Definition wise, severe osteoporosis, anybody with a osteoporosis with a fragility fracture, and this can often be asymptomatic. Many of our patients sitting in the OPD, the old aunties would come and tell that they have low backache, which might be the only symptom that they tell us. And if you do a lateral X-ray or you do a vertebral fracture assessment, you pick up a fracture there. So yes, uh, presence of these markers is helpful. We do use a lot of bone turnover markers here at Velo, both beta cross labs and P1NP. I think the key message there is if the beta cross labs are high, these are bone resorption markers. Denosumab like drugs would work wonderfully. More the beta cross labs, higher the response with drugs like denosumab. We from Vellore have actually looked at normative data of beta cross labs in young women and elderly women, and we have our own normative ranges for India available, and they are really, really helpful in managing osteoporosis. So yes, there are a lot of questions coming in, a lot of new people joining in. A very warm welcome to Dr. Shashi Khare as well. We'll take your questions in a while, but for all the new listeners who just joined in today, friends, today we are discussing about osteoporosis. We are talking about denosumab and its role across the spectrum in patients with osteoporosis, in patients with comorbidities. We're trying to see how we can understand better the use of denosumab with the experience that we have on board with Dr. Manoj with us today. So moving on, we've talked about assessing risk of osteoporosis. We've talked about combination therapies, and a question that Dr. Shashi Khare has asked us: how long you can use bisphosphonates, and can you really use denosumab uh, prophylactically to prevent osteoporosis? Maybe I'll take that first answer. How long we can use bisphosphonates? I think the answer is for many years you have to use it. You have to keep reassessing their bone mineral density, see the improvement in density, and try and find out. Yes, even for denosumab, we have data. We'll talk about it, how long we use it. But the question Dr. Shashi Khare has specifically pointed out: can we use denosumab prophylactically to prevent osteoporosis in postmenopausal women? What would you say?
So I think that's a right kind of an indication for women who are post-menopausal or basically long-term steroids, or the ones who have been through the breast cancer scenario, those conditions. Denslob is definitely something that is gonna be well tolerated and a potent and established patient treatment for these kind of osteoporotic patients.
Absolutely right.
Regarding
So
that question, I think uh, though we have not used it that far, and because the indication the time availability is lesser out here, we use it 68 milligrams subcutaneous every 6 months going on, and we have indication going on for a couple of years. But the data, if you go back, goes from 5 to 10 years as a safety profile in succession.
absolutely. And today, I think world literature would endorse 10 years usage of denosumab without any problems. This is another very, very important message we'd like to leave with all our audience. And we're also very privileged to have Dr. Sanjay Kalra, who's joined us today. A renowned physician, needs no introduction on any national or international platform. He's been the immediate past president of the International South Asian Federation of Endocrine Societies. And Dr. Kalra has posed a question that sometimes in clinical practice, we may not have bone mineral density easily available to us. So he's asking what risk scores can we use to quantify osteoporosis and fracture risk. We've talked about FRAX. Any other risk scores would you like to mention, Dr. Manoj?
I am laughing because endo should be answered by endocrinologist,
All right.
not
So
not
let me take that.
the
No worries. Let me
You
take
take
that.
it
So
up.
yeah, so we have a lot of risk scores which are available. Again, I know of data from our own center here in Vellore. We published about 10 years ago looking at the usability of simple risk scores like SCORE, SCORE. If you just put it on Google, SCORE for osteoporosis, you get a simple tool without usage of PMD. You get a risk score. This is validated in the Indian population, something that can be done very easily. And those patients who have a high risk based on score, both for men and women, there's a separate criteria, very similar to the way we calculate GFR. In patients with diabetes, we want to find out the GFR for finding out their diabetic nephropathy status. Similarly, we have these scores for osteoporosis assessment. Another one which is commonly used is MODES. This is commonly used in men. And there is another one called OSTA. So I'm giving you with three scores. One is called SCORE, OSTA, and MODES. And these are simple tools. Just use age, weight, the years of menopause, usage of steroids. So, yes, all these are very simple tools that can be used and are helpful in clinical practice where you do not have bone mineral density. Another question that has come up on the chat box, and maybe I could take that, is regarding how do we find out whether a patient with diabetes is at an increased risk of fracture or not? And this is especially important because FRAX does not have diabetes included. Now, the important thing is that Frax has got updated in the last year, excuse me, and then we have today what is called as Frax Plus. The University of Sheffield has come up with something called as Frax Plus, which incorporates diabetes. But if you're still used to looking at the old Frax, you could just replace rheumatoid arthritis with diabetes. If the patient has diabetes, you tick yes for rheumatoid arthritis, and that's one of the scientifically validated ways to find out whether a patient has high risk of developing a fracture based on fracts when we don't have diabetes. We're getting a lot of comments and a lot of people have joined in. Warm welcome to even Dr. Geeta Agarwal, who's sending her greetings. And a lot of questions are pouring in, but let's continue our discussion further on. So far, we've talked about is denosumab, how do we use it, how do we use it in combination therapies, how do we use it as a post-operative modality to improve prevention of fractures even in the transplant setting. But I think a very important question and a very important indication for denosumab is usage in patients with chronic kidney disease. So, Dr. Manoj, how often do you see in your practice patients who have a slightly elevated creatinine and we cannot use any other anti-resorptive or any other anti-osteoporotic agent? How often do you see that in your practice, and how denosumab is useful there?
So nowadays, the number of these kind of patients is gradually increasing because of improvement in life expectancy of these patients, of CKD also, because of the availability of dialysis at all corners, better management of these conditions. So these numbers are now increasing. These numbers are increasing to us for the management of osteoporosis with these treatments, as well as these patients coming to us for the management of arthritis also. So, since the other modalities, because of the high kidney profile GFR levels, are not very safe as prerogatives to be used in, denosumab becomes very safe in these kind of CKD or renal impaired patients.
Absolutely. So, a very clear message again to all our listeners. You can easily prescribe denosumab irrespective of the renal failure that a patient has. Denosumab is a drug which is metabolized through the liver, and you do not worry about the GFR when you prescribe it, which is not true with either teriparatide or any of the bisphosphonates. So, this is a very big advantage. And many times, patients with bony problems have consumed a lot of painkillers. Sometimes they even have these native medications, Ayurvedic, homeopathic, and some of them with the heavy metal problems do land up with CKD. And we need to be aware of using this particular drug even in patients with CKD as well. So, if we are now moving on to a more practical domain, when we really have to prescribe, you've already mentioned the dose, 60 milligrams subcutaneously given twice in a year. If I may ask you, what are the precautions that we need to take before giving denosumab? Are there any specific things that I need to look into in the clinical profile or the investigation profile of the patient?
So I think one of the baseline that we all carry and we keep telling to all our youngsters is assess the blood calcium levels before you get it, and they need to be corrected if low because this drug causes hypoglycemia. So basically, your calcium levels have to be in a normal range, and if they are low, they need to be supplemented, normalized before you start administering. Also, a word of caution for pregnant, lactating mothers, as well as the patients with latex allergy. In all those parameters, you'll be very cautious before using this drug. But normally, for all other portfolios, it's a very safe medicine to be used. And one can really go ahead on the safety profiles, on to the ease and administration of usage because it's subcutaneous.
Absolutely. And maybe if I have to add to that, Many
Yes.
times when we are prescribing other anti-osteoporotic agents, we are often worried about gastritis, acid peptic disease, and many of our Indian patients do have this problem with any drug that you prescribe. I think this is another big advantage, unlike other drugs which have to be taken orally on empty stomach with a glass full of water, cannot lie down. So all those problems are kind of waved off when you're prescribing denosumab, and so that is another important aspect that we can look at. Overall, the safety, especially of denosumab, is quite okay, and can be used without any hesitation. There's another question which has come up, which talks about denosumab in osteoarthritis. Can it improve the joint health as well, in addition to the bone? What would you say?
So there are a very small number of studies I was reading through across on these things on the users with the patients of osteoarthritis and a small subgroup of patients for hand arthritis. They really found out that it not only stopped the progression of erosive osteoarthritis, but also helped across in reversing the damage. But we do not have a lot of literatures for the knees and hips that okay, you give denosumab. Apart from strengthening the bone, which always it does, it causes a structural change to reverse the arthritis. So very small number of studies, they are positive, can be used, but a lot of data on osteoarthritis prevention is still not there in the ground.
And I think this is a message again. I think even for everybody who's listening to us, and if you have used denosumab in practice, I think you should collate that data. You should publish so that we get more robust scientific data to support its use in joint arthritis, because that's another very big problem in our society. I particularly deal a lot of patients with a lot of patients with obesity in the obesity clinic, and osteoarthritis is a very common problem that we have to deal in clinical practice. And unfortunately, we do not have very effective drugs to manage that as such. We see that a lot of other people have joined as well. A warm welcome to Dr. Geeta Agarwal, Anamika Anu. So, again, the question is cropping up. And I think this is a very common question, Dr. Manoj. I think we need to re-highlight how
Yeah.
long can we use this denosumab in clinical practice.
So of course, majority of us say 3 to 5 years, but there is a evidence-based medicine amount of data to say you can safely use this medicine twice yearly for up to 10 years.
Absolutely. So, yes, 3 to 5 years, you keep reassessing the fracture risk, but up to 10 years, it's not a problem. But after you stop denosumab, you need to make sure the patient does
Yeah.
get another anti-resorptive or another anti-osteoporotic agent so that the treatment can be continued. You do not stop it abruptly. And this takes me to another realm of questions. And most of our patients are very well read with the Google and the YouTube universities, and they have all these questions. And no matter how often we are convinced how good a drug is, the patient would still ask you, doctor, what are the side effects of this drug, especially when they're spending a little bit money for the drug. So, what would you tell your patients about the side effect profile? And you mentioned it is very safe, but what would be the exact answer to a patient?
So generally, this swab is very safe. Some sort of back pains, muscle twitching, itching, spasm, scaly skin, that kind of features. Basically, you have to look in what are the features of hypocalcemia. Those kind of side effects you need to be covering up. Also, slight risk of infection because of decreased immunity. So these are the kind of scaly skin, stiffness, general aches and pains. These are the only things that we found in our patients as side effects. Now, Dr. Nitin, since you use it a lot of other patients apart from orthopedics, did you find some other downsides?
Not really. In our clinical practice, apart from the things that you mentioned, which also I would say is rare, I think
Yeah.
the side effects are much more common with other anti-osteoporotic agents, but uh, very rarely, and these patients would find these side effects on Google and YouTube. And I must mention that there are side effects which are mentioned in terms of osteonecrosis of jaw or atypical femoral fractures. Now, I would say from our own experience at CMC Vellore, one of the really large institutes where we have 12,000 patient OPD every year, every day. And I would say that in the last 15 years that I've been here in the department, I've just seen 10 atypical fractures from all anti-osteoporotic agents. So sometimes there's a big scare of these side effects, whereas when we put in perspective, it is one in a million chance. So we don't really think of those one in million chances when you're talking of a benefit, a relative fracture risk reduction of about 70% by using this drug. I think that has to be negligible. And it is very important for us to convince and tell our patients about the reality about these side effects rather than just have big names of side effects, which are extremely, extremely rare, not seen. And again, if not used, if used in the correct perspective, somebody who's just had a recent dental procedure, I would defer usage of denosumab maybe by 2 to 4 weeks rather than giving it just adjacent to the dental procedure. If somebody is already using it for 5 years and I see the bone turnover markers are really low, maybe I can give a drug holiday, use another agent in the meantime, and therefore prevent these problems. So I think if your doctor is managing bones, bone health, be it orthopedics, endocrine, physician, geriatrics, if they know they are managing, osteoporosis, then you should be pretty confident that these drugs are pretty much safe. So yes, there are again a lot of questions pouring in. We have different people asking about again usage of denosumab, and we've talked about side effects. We've talked about duration of its use, and again, since we're talking about the heading of using it in comorbidities, I think one area that we've not mentioned is cardiovascular health. And we know that bisphosphonates are associated with some kind of rhythm abnormalities, but again, very, very rare in that. How would you compare denosumab in terms of using it with rhythm abnormalities?
So the question is, these cardiac patients, not primarily what we manage. We normally take in loop our endo teams as well as the cardiac teams. But as per the inputs we could get from them, because it's not prima facie our decision, they found it completely safe and not associated with any risk of composite and specific cardiovascular outcomes for patient treating these patients. But this, let me be honest, is not prima facie our answer. This is what is in loop with the other specialist colleagues also.
And maybe
But
if I could
we
add
can give
there,
an insight because I don't manage the cardiac patients. The only thing is we take an insight from them, and they feel that in all kind of cardiac comorbidities we can use this medicine.
absolutely. Rather, I wouldn't use bisphosphonates in a patient who's got an underlying atrial fibrillation or rhythm abnormalities. But when we look at literature available for denosumab, new onset atrial fibrillation is extremely rare with denosumab as compared to this. So, since we are talking of comorbidities, I think apart from renal disease, we can include even patients who have an underlying cardiac issue. This would be much safer than the other drugs that are available. So we've talked a lot about osteoporosis. We've covered a bit about osteoarthritis. And Dr. Manoj, you did start and mention about a lot of other indications as well where we use denosumab. So for the benefit of all our listeners, if you could just enumerate beyond osteoporosis, have you used denosumab for anything else beyond osteoporosis?
Patients with giant cell tumor of the bone, we found an improvement of the bone mineral density in those cases. In patients with the glucocorticoid-induced osteoporosis, patients with prostate cancer or a breast cancer on those treatment modalities, and also skeletal events with patients with multiple myeloma. So those are the real and bone metastasis. These are the kind of patients because in any case with treatment, these patients have a lot of them have hypercalcemia, which actually is benefited by taking delisrab because the calcium level also gets normalized. But in a lot of these malignancy conditions, myelomas, multiple myelomas in giant cell tumor, glucocorticoid-induced osteoporosis, there is definitely a subset of space for using denosumab for these kind of patients.
Absolutely. So you see, the scope of using this drug is beyond osteoporosis. Very rightly mentioned all the indications and multiple myeloma, especially again to highlight because this is a condition which not only has hypercalcemia but also CKD or elevated creatinine, which defers us to use any other drug. But denosumab is safe in CKD with hypercalcemia. Maybe if another indication, which is not so common, but sometimes in patients with primary hyperparathyroidism, when they have hypercalcemia, they have very fragile bones and they often have renal stones. Again, a risk factor for getting a kind of acute or a chronic CKD with them. And therefore, we can use for reducing hypercalcemia before we subject these patients to surgery. So, a whole lot of indications, malignancies, primarily prostate and breast, where we're using anti-hormonal therapies. But even for metastasis, as was mentioned, patients have hypercalcemia, they have severe bony pains. They are, if the metastasis is severe, they can even develop a fracture. So yes, in those patients, these drugs are useful, and maybe in even more frequent doses than the usual cases with respect to for osteoporosis. So yes, we can use these medicines beyond the realm of osteoporosis alone. So taking this further and
It's
again,
also, I think, a message that has to go on to the listeners today is that we definitely give therapies. What is very important, as you also said initially, is just don't abruptly stop it over. I mean, in our practice, when we stop Denosumab, we switch them over to bisphosphonates as a continuation therapy. One should not abruptly leave the anti-absorptive therapy, because otherwise you have a lot of rebound phenomena. So that, I think, a very
absolutely.
important message for the listeners.
Right? And this is something that we saw during COVID, and many of our patients who were on these drugs couldn't come back for follow up. They really didn't know what to do. There was no doctor to contact, especially first wave and second wave. And that is something that has really taught us in real lifetime, how they can be affected. A very, very important message, I would say, Dr. Manoj. Thank you for highlighting that again. We do not stop denosumab abruptly. If you are deciding to stop it, you should follow it up with a bisphosphonate or another anti-osteoporotic therapy. Keep that patient on close follow-up and give the medicine for osteoporosis in continuum. And again, I think looking at the Indian mentality of many of our patients, yes, they may worry a lot about spending very little for some things and just ignore a bigger risk or something that they can prevent with the use of these medicines. Sometimes when there is a comparison of cost between one drug and the other, and how would you convince your patient again about the cost benefit ratio of denosumab as compared to other anti-osteoporotic agents?
See, in any case, if it is in comparison to bisphosphonates, the cost is lesser, but the effect is way lesser as compared to Denosumab. When I see this in combination with zoledronic acid or teriparatide, all are into a single spectrum part. And overall, the cost benefit ratio is definitely on the positive side. Look at the speed in which your BMD starts turning back towards an improvement scale onto your vertebral level, on the hip level. Along with that, the decrease in the chances of any fragility fracture in a high risk population. This is definitely a cost benefit associated with this. And if I say head-on-head comparison therapies, this versus hyaluronic acid, this versus teriparatide, I mean, this definitely scores way higher, but the cost of all these three things are higher than bisphosphonate levels.
Absolutely. Right. And I think talking of terms of numbers, and even if just looking at numbers of cost, I think we should also look at the impact and the efficacy. And when we have different trials for bisphosphonates, we're looking at a relative risk reduction of fracture of about 50%, whereas about 70 to 80% with denosumab. So I think the number needed to treat overall, when you talk in scientific terms, the cost benefit ratio, the number of people landing up with fractures in orthopedic clinics would be less, and the quality of life of these patients would be definitely more. We have another audience question now, and they're asking how frequently we should call for follow-up of these patients. So if you're given denosumab to a patient with osteoporosis, how frequently would you call them for follow-up?
See, our reviews normally with all patients are 3 to 6 months, and these patients are called at the same time, and we have different analysis of the markers done across. So we have never found anything as an impeachment in our protocol. 3 to 6 months is our follow-up duration. Now, I do not know whether that differs in any of the endocrinologist management of these osteoporotic patients. So I think your experience would put more light across on these things.
Sure. And I would say that I completely agree with what you're saying. In our osteoporosis and metabolic bone disease clinic, when we start on any anti osteoporotic therapy, though we know that we wouldn't do a DEXA scan every 3 to 6 months, we would call these patients every 3 to 6 months, look at their bone turnover markers, see how the compliance is, see how the patient is feeling, with these medicines, how their calcium and vitamin D intake is happening, which is equally important to emphasize. You just give denosumab, you don't give calcium, vitamin D, it doesn't help. So these patients need a follow up. You need to see them at least in 6 months, but in 3 months would be ideal. 6 months is easy because 6 months is the time when you have to decide about the next dose. So you can see them at 6 months, but 3 months to assess their compliance, look at their calcium levels, look at their overall other bone health, if they've developed a new fracture or not, seeing their scores, and definitely do a BMD up to every 2 years or 1.5 to 2 years is something that is helpful. So I hope that answers that question. Another question which has cropped up in the chat box is regarding your experience to use denosumab. Is it better to use it pre-joint replacement surgery or to use it post-joint replacement surgery, and why would you choose one over the other?
So I work for a corporate setup. So in our cases, there's nothing like a pre-surgery because people who come in for the fine intervention. That's a frank and the right answer. So in our patient population, I would say almost everybody the treatment starts post-joint replacement surgery. I mean, in your kind of a setup, since it's a government setup, if you have something different as an experience, because in our setups, people don't come to us for multiple years before deciding. So we are the last shop.
Think that's true. Even for us, patients don't really come up much before, and they try and defer the bigger institutes till the last resort. We see them in the worst of their shapes, and it is often post and pre. And yes, if you do find osteoporosis, it is advisable to treat. I think the Indian Society of Bone and Mineral Research has done an exceptional, thing by sharing their national guidelines. Very, very practical. It talks about when you have to start treatment, when you have to screen for treatment, how you have to follow up, how you have to choose one therapy over the other, how these therapies work differently with respect to different sites, with respect to different types of fracture prevention, and the follow-up side effects. And I think I recommend all viewers to definitely look into that. Indian Society of Bone Mineral Research. It's a joint guideline by endocrinologists and orthopedicians, and that is very helpful. Dr. Manoj, I just don't realize how the time has flown, and we've
Yeah.
just spoken for 50 minutes non-stop. And I see the questions have been pouring in. People are thanking you for all the expert advice that you've been giving. And maybe I think we have just time for maybe two or three more questions that we are left with the time that we have. And what would be, again, a specific question? You've mentioned about secondary osteoporosis a while ago, but primary osteoporosis, yes, we've used this enough. In secondary osteoporosis, do you see the response is similar as compared to primary osteoporosis? What would you say? Somebody on steroids, would you expect a little different response, or would you say it's the same?
So for us, it is almost the same that we found through that whether you use a primary or a secondary. And moreover, you don't have many choices for secondary also. So there are very limited amount of choices you are left with to manage people coming with secondary osteoporosis. And more or less, I believe that this drug is really good and really effective. And for us, what is very important is the safety profiles. The safety profiles being good, easier to manage, very small amount of blood tests which are required for monitoring. These are also very important factors. And above all, what we found is the best part was the compliance part because it is subcutaneous rather than giving IVs and monitoring those patients in a daycare and adding cost to those in a corporate setup. This way, this was also helping us because the compliance was easy, management was easy, the effect is more like pronounced. It really gives you a potent endpoint. So with all these parameters, and in our experience, our sort of benefit scoring in secondary and primary osteoporosis is almost similar.
Absolutely. And maybe if I just add a small point to that, in our practice, when we see that the bone resorption markers are very high, which sometimes may be high in certain specific causes of secondary osteoporosis, the response expected is better. As Dr. Manoj in the first line itself mentioned about the mechanism of action, this is a drug which is working against the osteoclasts. Osteoclasts are resorptive cells, they eat up the bone. And if your bone resorption marker is very high, normal range suppose is up to 400 in your lab, and if the bone resorption marker of patient A is maybe 3000 as compared to another patient as only 600, the patient with a very high resorption would respond very well to this drug, because this is a drug which is directly hitting the resorption by inhibiting the osteoclast. So yes, that may be an indirect tool, but by and large the efficacy is so potent that it would be very effective either ways. We're getting compliments from different people who've joined us. Geeta Agarwal says, very well explained session. Dr. Lambe says, thank you, sir, an excellent session. Maybe just one other question from the audience, which has come up. Dr. Geeta asks about other medications that, if they are used with these medicines, is that something that is okay? Are there any medicines that you would avoid when you're giving denosumab? Medicines like gabapentin, omeprazole, are these okay to be continued with these with denosumab?
So as a broader profile, we always let them continue. Wherever in confusion, we route back to endocrinologists for a better review portfolio for certain things that we normally do not use. And if a patient is on specific medications, we normally ask that particular department for it. So I think, Dr. Nitin, you should be a better person to answer this question, because as an orthopedic surgeon, we don't find, if we get a cohort of patients into orthopedics and anybody who's on other medications, as a protocol we would always ask that particular substream.
Absolutely, and especially when we deal in endocrinology patients with diabetes, they are on a whole, big list of medicines. I think the two important messages that I would leave you with are that, definitely, as mentioned, denosumab is pretty safe to be combined with most other medicines. So yes, you can combine it with the medicines that you've listed, Dr. Geeta, about gabapentin, omeprazole, calcium. Not a problem. The second important message that I like to leave is that when patient is on concomitant medicines, we need to make sure that these medicines per se do not increase the osteoporosis, increase the fracture risk. Now, for example, in patients with diabetes, we have so many medications, but we know that maybe pioglitazone, thiazolidine is a drug that increases bone resorption, increases the risk of fractures. There was initial scare of also SGLT2 inhibitors causing hypercalciuria, though more recent meta-analysis have disproved that. So I think you have to be on the watch out for these other concomitant medications. If you have options to use drugs which are safe for the bone, use that. If you have options in rheumatoid arthritis to give a steroid sparing agent, maybe use that rather than giving steroids. So when you look at these drugs, not only look at the interaction, but also look at how their impact is on bone profile. Again, many thanks, Dr. Anamika, for your compliments. I think with this, we are coming to an end for this session. And may I request Dr. Manoj to please tell us a few key takeaways that you'll ask all our listeners who've joined us today to remember from this particular discussion. I don't know how 1 hour has just flown by.
Yeah, I
And
think for listeners who joined in late, let me sort of comprehend what we had discussed today. So denosumab is a potent and well tolerated treatment for treatment of osteoporosis compared to all other anti-resorptive agents. It affects and controls the osteoclasts at a very early stage before it binds onto the bone, adheres to the bone, and that is why they inhibit bone resorption. It is a safe drug, can be used for 5 to 10 years. But whenever you leave this drug, please use some other anti-absorptive management. What we use is bisphosphonates in those cases as a carryover effect, so as we do not have a sudden drop of bone mineral density in these cases. Now, as compared to other classes of management of anti-absorptive agents, this gives you continuous increase of bone mineral density compared, and does not reach a plateau as we see in other cases, because giving a treatment Having an improvement of BMD is one part, but a continuous improvement is the other part that we need to look into. Many other treatments that would give you a plateau effect. This does not give you a plateau effect. Also, it has a very good impact on lower chances of non-vertebral fractures among the aging populations. So the duration, you can easily continue for 3 to 5 years. There is data to support you can even continue about 10 years also. So, apart from the primary osteoporosis, which is the direct indication, we discussed a lot of parameters of secondary osteoporosis, lot of giant cell tumor, multiple myeloma, breast cancer patients, dialysis patients, safe in CKD patients. So, this is a nutshell about this drug. Very, very safe in the current domains. An excellent choice, gives you a good cost benefit ratio to your patients which you are managing for osteoporosis in a geriatric population, postmenopausal population, or all the secondary causes that we just mentioned across with you.
So thank you so much. I would say that these are practice pearls, very seldom spoken of. And thank you so much, Dr. Manoj, for joining us today. I think it was a great session. Again, there's a lot of appreciation coming in the chat box. Thank you for all the listeners for joining us and such an interactive and active audience that we've had today. I think this was a real treat for all of us, learning about management of osteoporosis, learning about management of usage of denosumab in treating osteoporosis from the great clinical experience that we've learned from today. I think a big thank you to you, Dr. Manoj, and a big thank you to our team from Alchem for thinking about this and I think addressing this very, very important topic. I think with this, we'll close this session. A very good night to all our listeners, and we hope you will join us again for another session on metabolic bone disease next month as well. Thank you.